Alex Martusiewicz. I'm a current orthopedic resident at Northwestern University. Today I just want to touch base a little about kind of rotator cuff pathology in general. Specifically later on in the talk we'll focus on partial articular tears, which is kind of a gray area in orthopedics, sports medicine. Right now, common injuries that we see especially in overhead athletes. In addition to that, just in the general population, any kind of overhead workers or people that put a little extra stress on their upper extremity. So we'll start off again talking about the anatomy. We'll classify these, and then a little bit later talk about what we can do about them. But in terms of the anatomy, this is typically how our rotator cuff is set up when it's healthy. And again, one specific area to focus on is kind of the anterior aspect of the supraspinatus insertion, which is over here in this area. This is a region where we see especially a lot of the partial tears. And most of that is thought to be due to potential issues with impingement as well. So if we look at this top part over here, our acromion, we have different kinds of morphologies. It's classified into 3 different ways, but the big thing is just taking a look at how it hooks. And this, if people are believers in external impingement, we can potentially have increased pathology when we abduct, internally rotate our shoulder with increased hooks on that acromion. This area over here can start to impinge on the supraspinatus footprint, where it inserts onto the humerus and start causing irritation, anything from tendinosis to partial and full thickness tears. What we'll also talk a lot about a little bit later is the interval that we use to repair. We've developed a technique that changes the way that we repair these, and there's a lot of controversy on the best way to do it. But as you can kind of see in this diagram, there is a gap in between the supraspinatus and the subscapularis here, which is referred to as the rotator interval. In arthroscopic surgery, that interval is used quite a bit to try and maintain the integrity of the rotator cuff tendons and also some of the shoulder capsule. The capsule, which over here on the diagram on the left, is broken up into a few different ligaments. You can see the glenohumeral ligament. There's the superior inferior glenohumeral ligaments. In the picture on the left, they look like separate entities and separate structures. Really, it's one continuous capsule, and these are thickenings of those structures. So what we'll be doing is talking a little bit about different ways to repair it to try and preserve the integrity of this cuff, and why we chose the method that we did. In terms of classifying these, when we, oftentimes we suspect these clinically, an MRI is obtained, and then the radiologist puts down a read, partial, full thickness, and they can oftentimes use different terminology to talk about what's there. What we'll be focusing on today, again, is a partial articular sided tear. And again, you can classify these based on how much you see is left intact and by which muscles are involved. Oftentimes you could see complete tears, which again would involve most of the rotator cuff, supraspinatus, infraspinatus, most commonly, occasionally with subscapularis involved as well. But again, we'll be talking about is kind of a specific rotator cuff tear called a pasta tear or a partial articular supraspinatus tendon avulsion. These are probably the most common types of partial tears that we see. You can see a couple different examples. The CID is a concealed interstitial delamination. These are oftentimes difficult to pick up on an MRI because in our fluid-sensitive sequences, our joint fluid can't actually make it into the defect there. So we don't oftentimes see that signal enhancing in that area. The reverse pasta would be our bursal-sided tear. And then the last one there is a full thickness tear. Again, when we're abducting our shoulder and internally rotating it, our acromion is lying on the superior aspect of this. And that footprint on the greater tuberosity is oftentimes impinging. Clinically, we can see that with a Hawkins sign or different impingement tests like the Neer test. And that's oftentimes why we see the tendinosis and the pathology on the distal aspect along the insertion. The issue is a lot of these tendon tears have issues healing, mostly to vasculature. The vascular supply at this area is not very good at all. And so for that reason, we commonly see persistent pain, persistent symptoms, and things like weakness. So again, initially, especially with our partial tears, we try to treat these conservatively, physical therapy, anti-inflammatories, but a lot of times, they're refractory to any kind of treatments. When we're examining the patient, again, history and physical are probably one of the most important things. Nighttime pain, radiation down to the deltoid. These are all things that we really want to ask for. Weakness, especially. These can kind of give us an idea of more significant pathology in terms of the size of the tear. Obviously, we would expect more weakness with a complete tear, especially if it's been a tear that's been kind of chronic and going on for a longer period of time. And then the other thing that we need to ask for with acute tears especially, was there an event that initially triggered this? Especially important with our younger population and athletes, was there a specific moment when they were pitching or throwing that they felt a localized pain, again typically anterior shoulder, kind of just below the acromion and clavicle, that caused it. This potentially changes kind of how we intervene, and again with our full thickness tears, we will potentially intervene a little bit sooner, especially in a younger population, because those again will not heal and they'll have a tendency to retract. But again, the history and physical is critical, especially when we're dealing with even older individuals. If they're if they don't have a lot of requirements for overhead activity, really the repair can be quite difficult just because of the quality of the tissue, and may down the line actually even increase shoulder stiffness. In terms of our physical exam, again, inspect, palpate, range of motion is key. Oftentimes rotator cuff pathology is masked by a frozen shoulder. So one thing that I think is very, very important is to make sure that we exclude a frozen shoulder, especially diabetics, people with thyroid or immunologic conditions. Make sure abduction 45, internal rotation. Make sure that they have at least a 90-degree arc of motion. Oftentimes we'll think that limitation in range of motion and their function with abduction is just due to a rotator cuff issue, that they can't bring their arm overhead. More times than not, you could be burned by a frozen shoulder, and operating on that will just lead to worse stiffness and worse outcomes. Oftentimes you could get those two at the same time, which is not uncommon. The main thing is to try and get the range of motion back with therapy at the frozen shoulder, and then potentially rotate or operate on the rotator cuff or strengthen the rotator cuff at a later time. In terms of some of the specialized tests that have been developed to take a look at some of the specific tendons and signs of impingement. I'm sure most of you are familiar with these, but again, these pretty much just localize different parts of the rotator cuff to try and get them to fire and see, how much strength they have against resistance. The near test for impingement, again, you can imagine if we're raising our shoulder up all the way, or if we have a very hooked acromion and not a lot of space in the subacromial space for the rotator cuff tendons to lie, we're going to start to have pain with the humeral head, specifically the greater tuberosity, hitting against the acromion. Again, in that specific region, we're having our tendons live there, so again, that can also provoke some pain throughout the rotator cuff insertion. Again, lift-off test, Hawkins test, hornblower test, these are kind of specific tests to try and isolate rotator cuff pathology. None of them are perfect, but I think by putting all those tests together in kind of a global picture, it at least gives us an idea of what to suspect going down a road for diagnosis. There is some controversy regarding imaging. X-rays are always critically important. Again, this is just a typical AP of a shoulder, but other things that I think are important are a Gracie view, which actually looks at the plane of the glenohumeral joint. It gives us an idea of arthritis, what the state of the articular cartilage is. Another important thing is to take a look at the space between the acromion and the humeral head. Superior migration, so elevation of that humeral head can oftentimes give us an idea of what the state of the rotator cuff is. Oftentimes with tears or, again, with impingement, you'll start to see glenohumeral elevation. And so, again, that's pretty much for any kind of orthopedic issue, X-rays are critical. They just give us so much more information. A lot of times people say, well, hey, you have a CT scan or MRI, you have the diagnosis here, but there's so much information that you see on an X-ray that you don't necessarily will catch on all the cuts of a CT scan or an MRI. So that should be kind of our go-to imaging for any kind of pathology. Then there is some debate between ultrasound and MRI. Ultrasound, I think, in pretty much every study has been shown to be very operator dependent. Very important, to have a skilled technician if this is going to be your go-to as far as a diagnosis for rotator cuff issues. But it has been shown to be reliable in terms of looking at MRI. versus ultrasound for rotator cuff pathology. They have very similar specificity and sensitivity, so I think either test is reliable. The one thing with the MRI, in most places, it is easier to obtain. I think there's less skill dependency with the MRI. The other nice thing about an MRI is that it gives you a broader picture of the shoulder. It is more expensive, but shoulder pathology can be somewhat tricky, and there's different things that kind of mask the symptomatology and the pathology that goes on in a shoulder. More often than not, you can be surprised that what is behaving like a rotator cuff tear on exam can, in fact, be some potential labral pathology, some biceps tendon pathology. Those things can be difficult to diagnose on an ultrasound. So, again, I think either choice is reasonable, but in terms of once you're starting to go down a surgical perspective, a surgical road, if conservative therapy has failed, I think obtaining an MRI is beneficial to see, hey, is there labral pathology? Are there loose bodies there? Is there subluxation of the biceps tendon that may be also causing these symptoms? It also gives us an idea of the state of the acromioclavicular joint, and it gives us a picture of any other tendinosis further along our rotator cuff. So again, this study does look at MRI versus ultrasound. They looked at 71 patients with different types of tears. And again, MRI was shown to be slightly more sensitive. Results looking at the chart are fairly similar across the board, very high percentages overall in terms of diagnosis. I think it's just knowing what your institution has available. I know, for example, I think physical therapists in general, so family sports medicine, family physicians are much more trained in ultrasound guided techniques. And so I think having that available and having that comfort level there is great. Unfortunately, I think in orthopedic training we get a little less of that, so we do put a little bit more weight on MRI. But I think both are great techniques to kind of have in your back pocket, and at least potentially go down a road of suspecting what's going on. So again, back to the pasta tear that we talked about previously. This is typically what you're going to be seeing on an MRI. Most of the sequences that we're looking at are looking for fluid filling up spaces where it shouldn't be. The synovial fluid in the shoulder and in the subacromial space are going to fill up defects in any kind of tendons or muscles that we see. We'll have more pictures later on, but this area over here where you see the increased signal on this T2 sequence, again, is showing, I'm sorry they're not coming up as nicely over there, and then you can see this is the anterior aspect of the supraspinatus. This is typically where we are seeing the pathology there, mostly because of the elevation abduction activities, the impingement involved with the acromion. That's the area of the rotator cuff that is most commonly seeing stress, and in the site of that we are seeing the tears in that area. I think these two are also examples that show it pretty nicely. For our partial articular tears, what makes them partial is that they're still part of the rotator cuff and footprint that are intact. You can see on this superior side, we still have some of the black healthy tendon on this sequence that is inserting onto the rotator cuff, which appears healthy. The area that does have some fluid enhancement and edema is on the articular sided surface, as well as on this picture you see the same thing. The other difference would be is that if this was a complete tear, you would expect some retraction of the tendons, especially in chronic tears that have been going on for 2 months. You start to see some fatty infiltration, so you would start to see some high-intensity signal in the supraspinatus, especially on sagittal plane imaging, and then you would see retraction of this tendon. In fact, it retracts as far as to the glenohumeral rim, or the glenoid rim, and even past that, which again potentially change our treatment options. So the biggest thing with these injuries is to try conservative treatment. Overall, they do very well, especially in younger patients. They're able to tolerate a little bit more of an aggressive physical therapy regimen. Our goal is to get strength back, range of motion back, and have pain relief. Pain relief is usually one of the most difficult things to get back with these kinds of injuries because regardless of strengthening of the rotator cuff, you can potentially change your activities, change your biomechanics a little bit. But if you start going back to the same activities that potentially cause this chronic tear, you're just exacerbating the same area. And again, we talked about the vascularity of the cuff. It's just not something that repairs itself on its own. But almost all the time, people do respond very, very well to conservative treatment, which again would include anti-inflammatories, physical therapy, range of motion improvement, strengthening of the shoulder girdle, and also other parts of the rotator cuff. And the other option would be a corticosteroid injection. Now, the difference between, I think, partial versus full thickness tears that is very, very important is the fact that a partial tear, we don't have evidence yet that it necessarily extends. It is, presumed that there is a risk of that, but we haven't had a lot of great data that shows that. So, I think with these, we do lean towards more conservative measures to see if we can get resolution of symptoms. With a full thickness tear, in a patient that would be a potential surgical candidate down the line, I think the last thing on this sheet, a corticosteroid injection, would be somewhat questionable, especially since you could get a little bit of degradation of the tendon after an injection like that. If, however, that patient doesn't have any kind of aspirations of operating on that tendon, I think at that point it would be more than appropriate for symptomatic relief. If we have a 70-year-old individual that does not have a lot of need for overhead activity, I think it's more than appropriate to just continue conservative treatment. I think, in fact, unless they were very, very adamant about operative treatment of their rotator cuff, I think for almost everybody at that point, I think it'd be excellent to just continue the conservative management, anti-inflammatories, cortisone injections, mostly because our data has shown that the improvement in function, the improvement in strength isn't that apparent. Our repairs are usually less substantial just because of the quality of the tendon to repair back to the bone. That being said, there's a physiologic age and, the given age of the patient. Those can be two very different things. So, again, a lot of this should be individualized per patient. So in terms of our indications for surgery, we're looking, a failed conservative management course, progressive weakness, and then, again, a accurate diagnosis of a rotator cuff tear. If the tear is asymptomatic, again, why would you operate on it? This is all for symptoms-based. These are elective procedures to help improve what we discussed. We discussed chronic tears or massive tears. Again, if we see a lot of retraction past the glenoid, it's very, very difficult to pull that back and get it back to our footprint. So for that reason, those we can continue physical therapy to potentially strengthen other rotator cuff muscles, but operatively it's very difficult to bring it back to the footprint to get any kind of function back. We touched base on a frozen shoulder, which again is an important diagnosis and can potentially happen at the same time as a rotator cuff tear. Again, specific people that should be on your radar. For some reason, we know that diabetics, people with thyroid and immunologic conditions can get this, and operating on this would just make it worse. We need to make sure that we get our range of motion back first before we start any other kind of therapy or discussion of surgery. And then in terms of techniques, this is kind of the heart of our work that we've been doing. There have been several different techniques to potentially fix a rotator cuff. First off, people have just tried debriding it and kind of debriding the osteochondral area on the humeral head to promote and stimulate a little bleeding from the bone that could potentially form some scar tissue to the tendon. We talked before on how the acromion has a lot to do with potential impingement and irritation of the rotator cuff. So an acromioplasty would just be shaving the undersurface of the acromion to provide a little bit more space with a decompression, getting rid of the bursitis and putting a little bit more space in between the humeral head and the acromion to allow for the rotator cuff to move around. In terms of repairing the rotator cuff, the traditional thought would be to complete the tear and fix it traditionally as if it was a full tear. Again, this is if it was continuing to be symptomatic. The issue that we thought with that was that there is healthy tendon there that is still intact, and you're cutting that tendon out. The con to that, a lot of people will argue that it's a lot more difficult to tension the tendon appropriately to repair when you're only doing a partial tear. There have been different kind of methods of leaving that intact rotator cuff and repairing around it. This diagram over here shows a trans tendon technique. The one issue that we had with this technique was that the anchors that you're putting in to repair the rotator cuff are about 5 millimeters in diameter, at least 4. So you already have a partial tear in the cuff, and then you're putting a 5 millimeter defect in the cuff. There's the tendon that is intact, you are putting a giant breach through. There's a trans-osseous technique which actually drills holes through the humeral head and avoids this intact footprint to put the repair through. But then again, the procedure is a lot more difficult. You have outside-in techniques, and anchoring your suture bridge to potentially repair it is proven to be slightly difficult. What we have kind of developed with Dr. Terry at Northwestern is a trans-interval technique. We talked about the rotator interval previously, but whether you're looking from outside in or inside out, arthroscopically, there's different landmarks to define this interval. In general, it's going to be the space between the supraspinatus and the subscapularis. Again, really where we only have ligamentous insertions, and we're not putting any kind of breaches in the muscles. When we're looking from inside out, you have the coracohumeral ligament and the superior glenohumeral ligament arthroscopically that define some of our landmarks. Pretty much for any kind of shoulder arthroscopy, that interval is used very, very commonly because of the lack of important structures that we're going through. Again, we're pretty much able to go through skin, maybe part of the deltoid muscle and capsule. We're not putting any breaches in our rotator cuff tendons or even most of our ligaments and capsular thickening. So that interval is very, very commonly used in arthroscopic surgery, and wanted to try and apply it to this kind of rotator cuff tear. The one difficult thing with this is the trajectory of our anchor to potentially sneak past all these structures and still put the anchor in an appropriate position, because you're kind of riding over the top of the humeral head. And again, that kind of triangle defines the rotator interval arthroscopically. Again, it's kind of superior to the subscapularis. The biceps tendon is living over here, crossing over the top of the joint, and then right above that is the supraspinatus. So again, that's kind of the area that we're shooting for with this. And as you can see, over here is the top of the humeral head, and for us to get through here, again, you could go above or below the biceps tendon. We really need a pretty acute angle to put down our anchor. But what we've been able to do with different positioning of the shoulder, kind of abducting it to give us the best view of our footprint, putting a little bit of traction on the shoulder, we have been able to, relatively successfully put these anchors in at this point. Again, this is one of our cases that shows, again, this tear from the rotator cuff. Again, it's just an articular tear. You can still see tendons on the superior aspect that are intact. And so the initial thing that you do is identify the tear, you debride this footprint, and you try and get to a osseous area that shows at least a little bit of marrow coming from this area, a little bit of blood potentially to aid in the healing of the tendon when we repair it. The next step is inserting the anchor. Again, with the shoulder abducted, we've been using titanium anchors to do this over some of the biodegradable ones. The biodegradable anchors have been shown to be very, very kind of friable, and they can break pretty easily even without the acute angle that we're putting it in at. But it's a 5 millimeter anchor, pretty much regardless of whether you're using, regardless of the technique that you're using. As you could see, putting that through the tendon itself puts a relatively large breach in it. And so this anchor is coming in through that rotator interval. It's avoiding the intact supraspinatus tendon. And again, after we insert the anchor, we pass suture lassos into that space, up into the subacromial space. Again, that's that space above the rotator cuff, and we're able to tie down the tendon through that interval. Again, we think that the benefit to using this kind of technique is that it respects the intact tendon, and it avoids, again, creating a breach in the cuff. We tried this technique on 14 patients, 10 males and 4 females, and with the average age of 56 and a mean clinical follow-up of 28 months. And the shoulder score scale that we used was the ASES scale, and it showed pretty much a 95 out of 100, 100 being a full functional range of motion and pain score, and very, very promising results that are comparable to other type of rotator cuffs repairs. 92% of the patients said they would repeat it again, and we thought it was a very promising study. Next step would obviously be to have a control group against this to compare the two different types of outcomes, and then again, I think big take-home points are adequate diagnosis, making sure that we distinguish between partial and complete tears, trying conservative management first, and then again, I think this transinterval technique provides another option for us that preserves the intact rotator cuff and provides pretty reliable pain relief and return to shoulder function scores. So references, and thank you to John Kukos, Mustafa Gambarawala, and Dr. Terry for doing the study and helping us out. Sorry. Questions?